We reported a phase 1 study of GDC-0810, which is a oral selective estrogen receptor antagonist and degrader. And this drug has a mechanism of action that is similar to fulvestrant in that it binds and degrades the estrogen receptor. This study, because it was a first-in-human drug, tested the agent in women who had been previously treated. It was estrogen receptor positive, HER2 negative, postmenopausal women who had had prior progression on at least 6 months of endocrine therapy. The primary endpoint of the trial was safety and tolerability, as well as to determine the maximally tolerated and/or recommended phase 2 dose. We treated 41 patients at increasing dose levels and found that at the higher doses tested, like 800 milligrams a day, that women did experience some nausea, some occasional vomiting, and diarrhea. So we lowered the dose and gave it with some food, with a meal, and found that 600 milligrams a day was most tolerable. What's very interesting about this agent is that it's oral, and the PK suggested good bioavailability.
Right. Now, in theory, what should a selective estrogen receptor degrader do for these patients?
So as we're learning more about mechanisms of resistance to endocrine therapy, we're understanding that about 20 to 50% of women have tumors that harbor an ESR1 mutation. Those mutant receptors are generally on or in an agonist conformation, even though estrogen levels may be very low. Let's say they've been treated with aromatase inhibitors. So the focus is now that we understand that there's these mutations, we're very interested in developing agents that target the estrogen receptor. So instead of reducing ligand like the aromatase inhibitors, we want to degrade these receptors, both wild type and mutant receptors.
Okay, so far, of course, this is a very early study, but what's the verdict on your GDC-0810?
Well, even though this was a phase 1 trial and really dose was the primary endpoint, we did also assess efficacy, and there was some promising activity. 2 patients have had a partial response to therapy, and it's notable that both of those patients had tumors that harbored ESR1 mutations. Initially, it would be developed to treat ER-positive, HER2 negative metastatic breast cancer. If it's proven to be safe and effective, it would be an alternative to drugs like fulvestrant. Fulvestrant is a good agent in vitro, but it was always troubled by the fact that it wasn't very soluble and required an intramuscular injection. And even with that, there's poor bioavailability despite high doses. So hopefully this drug might be able to, it's a pill, it's an oral agent, degrade the estrogen receptor and have good oral bioavailability.
Right, so this is interesting and promising news. What should doctors remember finally about your results now that are potentially of relevance to their clinical practice?
Well, we're learning a great deal about mechanisms of resistance to endocrine therapy, and as we're learning about them, we're really designing drugs that may be effective in patients who have endocrine resistant disease. So there's really a lot of new agents that are being developed as we understand these mechanisms of resistance.